Anxiety, in a way, it is the most common mental health condition here in Australia. Whole series of different biochemical um, challenges that happen that do produce the symptom of anxiety. So really today, and what I'm doing is I'm sort of going to sort of hone in on a particular subtype of anxiety there, but also at the same time just touch on various principles. I know that there's really, this could really in a way break out to be a long workshop to really give the full appreciation of exactly what's going on, but I'm just going to touch on various elements today, and but also appreciate that there is a lot more that I haven't touched on through this. So this is a bit of a supportive tool that we've just recently sort of produced there, and again it touches on again certain elements that are really good to reflect on, and it's a bit of like a 4-step process, and basically often step one, and essentially we can go through elements of it today, but what step one is really all about is basically about what can we use very quickly, very symptomatically when we're sort of dealing with patients. Because in appreciation of the different biochemical types and all the different things that are going on, sometimes you need a very quick, fast-acting tool to just give quick symptomatic relief as you start to investigate further in the patient over a series of consultations. Sometimes you can kind of jump very quickly in and start to sort of use the step one with the step two and even sometimes step three together. That's certainly plausible. But this is sometimes, we need things just to give some relief in patients, start to get them to get some confidence in the prescribing of how their condition is going to be improved. It's good to have that symptomatic tool. Step two starts to sort of delve into some of the different levels of this, and if you look at the left-hand side of that sort of diagram in step two, the neurological considerations and recommendations, this is where the steps start to go a little bit deeper into various neurotransmitters. The neurotransmitter hypothesis, neurotransmitter approach to anxiety is a very important one, and it's one that you can get remarkable therapeutic benefits in patients. And this sort of does look at the appreciation that sometimes you do need to do further investigation into whether one or a combination of neurotransmitters are not functioning or not available, or the precursors of them aren't used in the body. So the levels of them or the amounts of them in having an opportunity to have an effect just aren't there in patients. And so you've got the histamine and GABA and serotonin and dopamine and a whole series of sort of neurotransmitters there that we can go and investigate. Then the middle of step two, the immunological recommendations, this is really quite an interesting area, and it's really exploding in the research world. And it's really looking at essentially this oxidative stress. Pretty much every mental health condition, including anxiety, has this high level oxidative stress, and it's something that you just can't ignore. And even if you use a herbal combination together, the oxidative area is something that the herbal alone can't quite grasp it. You need to build in a whole other therapeutic regime to really get deeper effects. And this sort of has implications into the zinc and the copper imbalances and vitamin C's and P5, pyridoxine 5-phosphates, the B6s. This is where this sort of area comes in. And then on step two, you've got on the right-hand side, you've got the hormonal considerations. And this is to appreciate a whole other series of other imbalances, which relate to neurosteroids, various forms of derivatives of progesterone or low testosterone or cortisol imbalances, and these are the things that basically often interplay very heavily into anxiety that also do need to be to be reviewed and considered in creating a management program for patients experiencing anxiety. Then you've got step three. These are really considered the deeper or structural and functional considerations. These are sort of almost the baseline supportive tools that you can work on step one and step two, but step three is really quite important. This is where we do consider the nutrient, the full baseline nutrient status of the body's sort of processes there, and this is where you do kind of have a series of vitamin mineral profiles or antioxidant profiles or omega-3 profiles, This is something, again, that's very difficult to get long-term effect when you've got various imbalances at step 3. And at step 4 really is this, again, very, very important part of a therapeutic regime. It's really all those other lifestyle, dietary considerations. You really can't get long-term relief without implementing all these structural changes in diets and lifestyles and these kind of things that are very, very important. So really, in a way, it is this sort of, and I suppose step 4, one of the things that really needs to be considered is the cognitive behavioural therapy, because that's one that's very, very validated in the literature. So really, it is an approach that you do need to have a holistic style to get sort of long-term relief in patients. Just to kick off, really, in a way, the anxiety is as I mentioned, is the most common mental health condition in Australia. On average, 1 in 4 people, or 1 in 3 women, 1 in 5 men. So it is, women do experience more anxiety than men statistically. And so 1 in 4 women, 1 in 3 women, 1 in 5 men will experience some form of anxiety at some stage of their life. Over a 12-month period, about 2 million Australians experience anxiety. And when I mean anxiety, I also mean we all experience various anxieties when we drive to work and we're late, or we're sort of you do various challenging things, or something happens, the anxiety levels rise along with the stress levels. But generally, there's an ability for the body to modulate itself, and when the often when the stressor comes along, once the stress has been removed a little bit, the body has some regulatory capacity to reduce that experience of anxiety. But to be diagnosed with an anxiety disorder, the anxiety really has to have a very disabling impact on the person's life. It's really much more substantial than probably the anxiety that we all experience day to day and week to week. There's basically really 6 main common anxiety disorders. So you've got the generalized anxiety disorders, which I'll just abbreviate to GAD or GAD. Sociophobias, specific phobias. Sometimes sociophobias, people there's just overwhelming anxiety come out when they're in social environments. Specific phobias are just some activities that people might have a desire to desire to do something. Patients, you might have a person who, for instance, wants to act. Every time they go for an audition, the anxiety levels are so disabling that they can never fulfill that desire of the ability wanting to become an actor of some type. They just can't get past these auditions and these things, and they become really entrenched, triggers that just really disable people's ability to get where they want to go in life. Then you've got obsessive compulsive disorders, post-traumatic stress disorders, and panic disorders. But each one is quite unique in the way you approach it, and the biochemistry does sort of become more pronounced. But to sort of, I suppose, in the hour that we're doing here, I'm really just going to look at the generalized anxiety disorder. So really, this is the more pathological impact of anxiety that we'll go through and define in a minute. Having said that, a lot of things we'll touch on will actually work on the symptoms of anxiety that we experience in patients. When patients generally come through the door, they've got a whole series of things going on. Anxiety is often one of them in there, but there's many other things. So some of the things we're going to touch on today will also help with that, but we are going to focus more on the deeper, more pathological forms of anxiety today under the GAD. So really, to be diagnosed or to really define down what is the generalized anxiety disorder, it's really when you've got this excessive, it's really, really excessive anxiety and worry, and it's really occurring more days than not. For at least it's been occurring for at least around 6 months in duration there. And this is where the individual just finds it so difficult to control their worry. It's just that they can't, in an anxiety, they just can't control it. They try everything to try and relieve it, but they just can't do it. It's this heightened level that's occurring most days of their life. It's also accompanied by a whole series of physical symptoms, the heart palpitations, this whole muscular tension, this whole chest tightness, and quite a few other things. And really the anxiety and worry, to really get part of a diagnostic criteria, you need at least, I suppose, 3 of the following 6 symptoms that have been occurring for pretty much most days, for at least for the past 6 months. And this sense of this restlessness or really wired up, really keyed up, really always just on edge. The nervous system's constantly on edge. And as a result, it's just draining the body's resources. They're getting tired. Oxidative byproducts in the body are just causing damage to mitochondria and all these other parts of the body. So the ATP production is not working, and everyone's just experiencing elements of fatigue, find it difficult to concentrate. You know, the hippocampus has been damaged heavily by cortisol and these other imbalances that are occurring. They always have seemed to be irritable. There's muscular tension. And the implications of this are sort of coming on sleep disturbances. They have some, often will display some degree of just difficult falling asleep, or they get off to sleep, they wake up, they're just this restless, they never feel fully satisfied by the sleep there. So generally, at least 3 or more of those symptoms are the collection of the type of profile of person that we're going to discuss today and how to work with. The anxiety, worry, or physical symptoms, cause basically clinically significant distress or impairment. So like I said before, it's not that sort of transient one. We all experience bits of anxiety depending on the stresses that are coming into our lives. It's not necessarily that. It's much deeper, much more pathological. So to go into another sort of, I suppose, definition, the Diagnostic and Statistical Manual of Mental Disorders, or when you look at the 4th edition of the DSM, the Diagnostic Statistical Manual of Mental Disorders, the 5th edition, the criteria that they use to describe an anxiety or generalized anxiety disorder is really the anxiety, worry, or physical symptoms cause clinical significant distress or impairment in all elements of life, from social, occupational, for work, and other important areas of functioning. So it's just everything's happening in their life. It's just being affected, and it's just causing a significant level of challenge. So really, in a way, how this has been currently treated, in Australia, is that really for the last 50 years, they were pretty much treating this with benzodiazepines. We'll go through it and describe a bit of the benzodiazepines in a minute and some sort of functionality of what they're doing. But benzodiazepines, essentially, they work on the GABA pathways within the body, GABA being the body's major inhibitory neurotransmitter. It's a major calming neurotransmitter, an inhibitory one that calms the central nervous system down and brings sort of, I suppose, more relaxation type of feel and effect. So they were sort of using these benzos to treat. It's shifted now because of the risk-benefit ratio was just too problematic with benzodiazepines. So they started shifting it over and started using SSRIs, selective serotonin reuptake inhibitors, or SNRIs, this serotonin noradrenaline reuptake inhibitors. So as in a way, was basically looking at these mechanisms that once the body, out of the nerve synapses, creates and releases the serotonin or the norepinephrine or noradrenaline into the nerve synapses, the drugs are there to try to stop the body from sweeping it all away. So it's trying to keep those levels of neurotransmitters in the nerve synapses as long as possible to create the desired effect of that particular form of neurotransmitter. So that was really the first line of treatment that's being used in GAD, in the chronic anxiety disorders there. But now really what's happening is that the benzodiazepines are now used more of the second line. So they're sort of taken, they still use them. Often they use them in the that 4 to 6 week period when an SSRI and SNRI is being administered. It takes at least 4 to 6 weeks for it to sort of kick in and have an effect, if it's going to have an effect at all. It's usually that 4 to 6 week time lag. And then you've got this sort of period where the patient needs some degree of relief, and that's where the benzodiazepines are generally prescribed in. Having said that, patients can be on SSRIs or SNRIs as well, and often are periodically prescribed the benzodiazepines, because often, even on those particular drugs, the level of effectiveness or the level of anxieties still can become problematic, and during various times, the benzodiazepines are continually probably used throughout that treatment. I guess that the challenge with this, and we all are quite familiar probably with the elements and challenges with these this particular approach, is that it rarely leads to sort of some short or long-term remission. a particular study done a little bit while ago, but it looked into basically 5 years, and the remission rates were as low as about 38%. And that's a fairly even a positive aspect for it, but it's really, in essence, it's not really doing it. And I mean, when you look at the biochemistry, as we'll go a little bit later on, but we'll go through the biochemistry, you can see why, because trying to block just serotonin or norepinephrine in the nerve synapses and just trying to keep it there, the challenge is that some people just aren't creating enough, and you're trying to block what little element that is there. And the issue also is when you sort of use the SSRIs and SNRIs, you're blocking these neurotransmitters, but the receptor activity within those nerve synapse cells are basically downregulating. So the more you use an SSRI or SNRI and artificially create this sort of blockage, in essence, blocking the body's sweeping away mechanism that generally clears away those neurotransmitters naturally, when you're trying to block it in, the receptor activity in those nerves begins to atrophy. It begins to sort of downregulate. So the effectiveness of it doesn't really work long term. So they are plagued with, certainly have their benefits and they've got their place, but they are plagued with a lot of complications and just sometimes just essentially not working as well. Benzodiazepines have a very, very narrow window of I suppose, safety margin between becoming an anxiolytic and having a positive effect and having all its side effects. So it's a very narrow window, which is why they removed it from its first-line therapy and created another first-line therapy and reduced the benzos to a second line. And about basically 25 to 30% of all patients just don't even respond at all, purely because essentially the benzodiazepines, they don't know really how they work. They know it works on GABA, but sometimes GABA in anxiety disorders isn't the issue. So if you can approach it in this particular way, and GABA is not the neurotransmitter that's problematic or needs support in this patient, of course it's not going to work. Now, also the thing about benzos is that when you start to try to take a patient off it, receptor activity levels have atrophied, so you sort of start to pull this supportive mechanism away. If you don't have any other supportive tool to use, if you don't have any other nutritional status rectified, taking it away is taking away that little bit of supportive plank, and basically a lot of these anxiety symptoms and irritability and apprehensions and all these things generally sort of come flooding back. So it's often a real challenge to get patients off these drugs, particularly when they've had so many other forms of side effects and impedance to work performance and the other mood complications, and it's very difficult sort of place sometimes to work with there. And as I mentioned, I think before, the benzodiazepines just don't really quite know how they work, despite them being around and used in medicine for over 50 years. So just in terms of trying to identify one cause, it's just not really quite known exactly the cause of it. They do know is that the role of the inhibitory neurotransmitter GABA is really long regarded as pretty much the central neurotransmitter that regulates anxiety. And basically this is where the target of all the drugs are generally coming in on trying to work on. So at least they know GABA is a pretty much essential one, but not always implicated with every particular type of GAD patient. The GABA, essentially is the important one, but there's a whole series of other neurotransmitters, from the serotonin to opioid peptides, the endocannabinoids, the neuropeptide Y, oxytocins, corticotrophin releasing hormone. There's a bit of dopamine in there. There's a whole series of this web of neurotransmitters. So sometimes it's not essentially one that's dysfunctional, not one that's problematic there. Often it might be serotonin that's more pronounced. Often it might be more the opioid levels that are more pronounced. So often it's really a complication of this web of neurotransmitter networks that are dysfunctional or not working as well as they could. Even though GABA is essential to it, often there's other forms, and this sort of explains a bit why sometimes benzos don't work, or sometimes just focusing on maybe serotonin impacts don't quite work, because again, there's so many other neurotransmitters that haven't been addressed with this particular therapy. The neurosteroids, the things like even testosterone or the derivatives of progesterone, they also bind to GABA receptor sites, the calcium, the chloride channels in the body that regulate the GABA release. So they are very important, and you do obviously, and many would know their implications and roles of this derivative of these neurosteroids. Interesting, tying it back into the SSRI, they can see these neurosteroids in the central nervous system are upregulated. And this is where they believe that even though selective serotonin reuptake inhibitors are targeting the serotonin, they are having some implication and some impact over onto the neurosteroids, which is where I suppose the link between an SSRI being serotonin is also having some impact on the GABAergic system. So it's indirectly impacting the neurosteroids. So therefore, the neurosteroids are the ones that are working on the GABA system, and that's why SSRIs do also have, I suppose, a secondary mechanism. It's not just serotonin; it also implicates the GABAergic system as well. So just before I get into sort of an area that we can look into, what's been really fascinating looking through the literature, particularly on how we can target, and really in a way what I'd say these first line targets, particularly for really serious GAD types of conditions there. Carver's been coming through the literature for many, many years. At least for the last 10 years, there's been a whole series of even monotherapy types of approach that researchers are looking at just on the Carver. And what's happening right now is that there's a very large and very well-designed clinical trial happening here in Australia with the University of Melbourne, one of the major universities up here in Brisbane, and they're still in it started late last year, but they're still in the sort of the study design, the study process right now. But essentially, what they believe it's going to be is basically that Carver will be able to replace and become a first-line therapy, a recognised first-line therapy for generalised anxiety disorders. And that's quite pronounced to have a highly recognised, highly funded research trial. It's just looking at Carver alone, and often researchers like to do this. When you have the ability to speak to the researchers and kind of go, why don't you just do a combination where you really work on everything? They often go, well, we don't really know exactly what's working. If we just use one botanical or one ingredient, it really helps us to reduce the confounding variables and really know exactly what that one ingredient is doing. So it's just the nature of how clinical trials want to operate. But essentially they're using doses from 120 milligrams of the carbolactones. This is at a monotherapy all the way up to about 250 milligrams. But we do know when you start to sort of put things into complexes, you have a less reliance on that one botanical having all the principal actions. But it's really quite exciting to see such a high quality clinical trial essentially coming into Australia, being able to basically identify and show that the use of SSRIs, SNRIs, benzodiazepines can be replaced with a first-line therapy using Carver. So it's really quite a wonderful clinical trial that's coming through. But the approach for generalized anxiety disorders in terms of looking at a first-line therapy, this really provides, as mentioned a little bit earlier, a very, very, very fast-acting treatment option. It is, I say, symptomatic relief. I mean, yes, it's working on this whole web of neurotransmitters. It's not going into deeper, maybe mineral cofactor, biochemical, some of the biochemical imbalances that might be triggering off this approach, but it is actually having a really quick overview of all these neurotransmitters that are implicated in anxiety and has the ability to target them, and at least provides you as a clinician the opportunity to kind of go, look, I'm sort of working my way through this web of neurotransmitters and finding out which one's right or which one I need to readdress. But it gives the patient confidence in you because they'll start to get some really good symptomatic relief. And that gives you an opportunity between your first appointment and your second appointment to start to sort of delve deeper, do further questionnaires, further functional pathology tests or other forms of investigative diagnostic tools to sort of get more further deeper into really what's happening. So Ed mentioned, multi-targeted approach, and where you need time just for additional testing, different, additional investigation to find out some deeper causes that might be occurring and creating the symptom of anxiety in patients. It's been long regarded for Carver. I mean, meta-analysis where they pulled a whole collection of primary research trials together and sort of analysed, what are all these research trials and the primary ones in isolation? What are they doing? So basically researchers do literature reviews. They analyse all the research trials that are out there. They eliminate the ones that have problematic designs. They have unproven methods of detection or unproven methods, scientific methods to validate the process of it. So they remove all those, and they generally water them down to a series of clinical trials that they feel have been conducted in using proper methods, and then they sort of pull those together and create a bit of a picture and see what's kind of going on. So meta-analysis are quite useful tools. They do have their downsides, but they have a very positive side. And this particular one here, just a very, it was one of the early ones that came through, showed very significant impacts when they compared it to a placebo using Kava. It had a very, very, higher percentage of impact over. So really, in a way, they saw Kava extract as being an effective, really for symptomatic treatment for anxiety. So really in Kava, when you sort of break it down, and we get our Kava extract, we give it to one of the universities down in Lismore, and they sort of break down the Kava extracts and break down all the different forms of the Kava lactones and all the subtypes of it there. But really, when you look at the Kava lactones and how they're operating on a neurotransmitter level, they regulate this voltage gate, the sodium calcium channels. They work on the opioid, various forms of opioid receptors, because we know in some cases of anxiety, it's the opioid receptors that need support. They need to be targeted. Has an implication on dopamine, and this is why Kava can actually have positive impacts on depression as well as anxiety, because it's work on the dopamine, the dopaminergic system. It's got the histamine. Histamine is quite interesting because histamine often is implicated in patients who have anxiety that's free floating, comes and goes, it's not really like a situation around. It's just suddenly they're sitting there, this wave of anxiety comes over them. They really don't know where it's coming from. It's happening, and that's really a histaminergic issue. So Kava does work on elements of histamine. The cannabinoid monoamine oxidase type B. So basically the enzyme system that degrades and breaks down the serotonin, dopamine, norepinephrine, so it works on this monoamine type A. But really essential when investigators really look into Kava lactones, they really come right down and they look at the main target of them really still is the GABA, but it does have this sort of nice web of other implications, which is why it's working on so many systems simultaneously, which is why now it's considered, well, it will soon hopefully be considered as a first line treatment, depending on those results coming out in that particular study. This was a study, 2009. It was one of the first of its kind. This is where they sort of looked at anxiety that's sort of crossing over a bit of depression, and they basically had patients elevated generalized anxiety. They increased the doses, and they sort of got up to about 250 milligrams, which is probably considered up the higher end of monotherapy when you're just using one extract, one herb alone. Often they will get up to around 250. You can get down to 120 when you're doing by itself. And really, what the study found, even within 3 weeks, they found that Kava was equally effective in both anxiety and depression. Had no safety issues. They had no serious adverse effects. No liver toxicity issues. And really, in a way, the implication of this was that, or really what they were using when you sort of hone into the study, look down at the particular where they're getting their extracts from. The Kava was an aqueous extract, so it's basically water water extract of the rootstock and the source from Vanuatu. Prior to this, what was happening around the world and how they were using Kava, they started to use ethanol extracts, basically alcohols, to draw out the active constituents out of the Kava root or the Kava rhizome. And it was hypothesized that method of moving from a water extraction method to an alcohol extraction method was potentially drawing out other constituents out of the Kava root, which was very different to how Kava has been used traditionally through the Pacific regions. In the Pacific and traditionally, they've never used alcohol methods to basically draw out the active constituents out of the Kava root. It's always been water. So what was happening around the world was that manufacturers probably not aligning to how the traditionally carbon was used. We're using ethanol forms. And this is where there was a couple of case studies that came up where there was implications of liver toxicity as a result of using these ethanol extracts. And that created an issue and created a ban back in the early 2000s. But that essentially has now changed, but you have to use aqueous or water extracts. And that's where the safety level resides. In this particular study, and the reason why I want to include this in is often when you're trying to find a speed or a timing level, you might have patients, how quickly will this work for me? How quickly will a formula get a therapeutic result? This was a first trial of its kind where they did a double-blind controlled trial of passion flower in the treatment of generalized anxiety disorders. It was double-blind, it was placebo-controlled, so no one knew what they were taking. The researchers didn't know what they were prescribing over. The patients didn't know what they were receiving, but they were really trying to compare passion flower with benzodiazepines, the oxazepam, and they want to see the efficacies between the two. You know, how does the benzo work compared to passion flower? They've got old humble passion flower there. And it was a smaller trial design. It was 36 patients, so ultimately these trials generally are more smaller scale as you begin to upregulate the patients there. So generally future trials will look at 36 and go, okay, this gives us a nice little window. This might be a great thing, but ultimately you need to what's called power the study and increase the participant numbers and start to go up a little bit further. But it was a really good sort of picture of how this is actually working. It's basically done on 36 patients. They are patients diagnosed with GAD using the DSM-4 criteria. 20 women, 16 men between the ages of 19 and 47. And just the oxazepam basically is an anti-anxiety benzodiazepine. It's used for that sort of short-term relief of anxiety. They often do prescribe it over when there's anxiety and also depression together. What they found in the conclusion of using this after trialing it for 30 days, they said, look, our main overall finding was that passion flower extract and the oxazepam are equally effective, in the treatment. Basically, they are effective in the treatment of GAD, in this particular trial design. But the results show that no difference between the two anxiolytics were shown. They basically said passion flower is as effective as benzodiazepines in eliminating anxiety symptoms. So that's a wonderful thing to see a herb going up head-to-head with a drug like this. There is part of the red circle I've got on this particular slide there. There was a slight little variation between the benzodiazepine having a bit more of a slightly greater effect generally between around the first few days up to around the 20th day. Very slight differences between the two, but overall after 20 days of use, there was no differences in the end, and up to 30 days, couldn't find a difference between the two treatments. Another trial which was also helps to sort of demonstrate some fast-acting results of this, and basically quite astounding to see a trial design done like this in a hospital setting. Often it's rare to see these types of studies come through, but it's quite wonderful what they did. Again, use a pretty good quality trial design, so double-blinded it, randomized it, and placebo-controlled it. So good criteria. They pretty much had 60 patients. They had 500 milligrams of passion flower in a tablet form. So tablet does generally it should be breaking down within 30 minutes, at least within a 30-minute time window. So it can be between earlier than that. Often we do like capsules. Often they do release a little bit earlier in the stomach, but it's a tablet form. And anyway, it's basically patients before going into surgery, and often there's this sort of anxiety that occurs during this time window. They use a numerical rating scale from 1 to 10, 10 being the worst possible anxiety, 1 being not too bad. And they looked at different time periods. Looked at so they gave the passion flower compared to the control. They tested every 10 minutes, every 30 minutes, every 60 minutes, and every 90 minutes pre going into surgery. And quite astoundingly, they found that when you look at that impact of it, there was a dramatic reduction in the level of anxiety when they used the passion flower compared to the placebo. So it really helps to show how quick these herbs, this passion flower is actually acting in the body. It's actually really, really quite quick. and shows that you can get these particular quite acute results by using this botanical. Just on Magnolia, just want to appreciate that also how Magnolia is sort of working. It has a sort of a wide range of implications over, but again, probably just to show that Magnolia is primarily kind of working on impacting the GABA-A receptor again. That's one of its primary kind of targets, has a slightly impact on adenosine receptor. But overall, if you sort of look at all these botanicals in this particular design, this formulation design here, they do have a wide scope, wide impact over. So know that with using kava, the kava-lactones basically bind to the GABA receptors. They have various implications on the norepinephrine and dopamine. You look at the Ziziphus, it works in the serotonergic system. I might just flick on to the next slide just to move along a little bit there, but you can see that the formulation here, by using these botanicals, works in the adenosine, acetylcholine, the serotonin, GABA, the glutamate, which is a major problem, the norepinephrine and dopamine levels as well. So it does have this whole broad acting impact on where all these botanicals are coming in. And I think if anyone hasn't trialed it, at least trial it once. At least try it once. It's a wonderful formula. It's really it really works remarkably. So just flicking on now, just moving on to step 2, and this is sort of where, just to appreciate, even though that was almost like in a way where you can work as a starting point just to get some symptomatic relief, get some results actually happening there. Really, we do have to investigate further. We have to go into deeper challenges that are happening in the patient, and ultimately look at how do we use the nutritional building blocks, the cofactors, the vitamins and minerals. How do we kind of go deeper into the biochemistry and replace these or identify what nutrients are either not there or problematic there, and how to sort of support and provide this nutrient support in. And this is where we've got an MDA, mood disorder appraisal online system there, which basically is a great tool that it's a questionnaire form, and it helps to identify where the imbalances, neurotransmitter imbalances, can be occurring. It's a great screening tool. You can use it to sort of get a quick overview and assessment on a patient and work out, okay, maybe this neurotransmitter seems to be the one. By the patient filling in the form, spits out these results there. You get this sort of nice overview of which neurotransmitters might be problematic, and it just provides you with a screening tool that you can give you either a further investigation or gives you an opportunity to kind of address which neurotransmitter might be problematic. And really, anxiety, I mean, the high or low histamines, serotonin, norepinephrine, acetylcholine, glutamates, dopamine, adenosine, all these neurotransmitters can be dysfunctional, all require specific nutrient support for them. And this is where you can get further and more long-term results by replacing these nutrients, providing these building blocks there, the cofactors for these neurotransmitters, and essentially just getting more sustained long-term benefit there. We've got this neurotransmitter chart, so they're all available. These are all free and all available for everyone to have. This helps to sort of, I suppose, put these neurotransmitters in perspective, because it's often very hard to juggle them all and remember them all and figure out what's doing what. So this neurotransmitter chart looks at the functions of each neurotransmitter, the deficiency signs, excess signs, what nutrients are the precursors or to consider for supporting or impacting these neurotransmitters. And just a quick few cautions, contraindications as a quick snapshot to kind of go, okay, if I've got a patient on this particular medication, where do I just have to pause and further investigate and find out whether this is right to give this over? The circles here, all those red circles, are some neurotransmitters that can be implicated in producing anxiety. So it is something where further investigation often does need to be taking place to figure out exactly what could be problematic here and provide deeper support over. I'm sort of briefly mentioned on this particular before, and often when we're dealing with anxiety, you get, like I mentioned, you can get this free-floating anxiety that can often happen. It can happen quite it can happen quite suddenly, where patients always experience anxiety, but doesn't seem to be triggered off by anything. It just sort of comes in waves and then kind of goes off again. And histamines, is implicated in these free-floating types of anxieties there. And often we kind of think, oh, histamine, geez, we've got to be careful about this one. This is the one that everyone's allergic and everyone's overproducing histamine. It's actually not quite the case. You can actually have low histamine levels there, and through methylation status, have a low histamine impact to the body and actually have symptoms displayed by that. And the reason why is, histamine is a major neurotransmitter in the brain. There's about histaminergic neurons, there's about 60,000 of them. They have a whole series of other impacts over, but anxieties, free-flowing anxiety is definitely one of them that we have to sort of, again, keep an eye on this one. So moving into oxidative stress, I'll try to move a little bit quickly, and sorry if I'm going through a bit fast and it's missing some points and making things maybe not as clear where it could be clear, but we have to go into oxidative stress. It is so important, and the reason why is that most mental health disorders, including anxiety, involve high levels of oxidative stress. It can contribute to the pathophysiology of anxiety disorders. There's association between the oxidant and antioxidant levels and anxiety disorders. High-level anxiety can basically just automatically increase the oxidative stress. So whether it's a cause, whether it's a result, it's something that has to be addressed. And basically oxidative stress and all these free radicals that are produced basically drain the body's vitamin mineral resources, drains them all, drains your vitamin C, drains your zinc, drains all your P5Ps, drains all those particular nutrients to try to sustain this level of oxidative stress, which is the byproduct of anxiety there. So sometimes oxidative stress can be a precursor or a cause. Sometimes it's not primarily the cause, but it's the result. So some people may have, oxidative stress wasn't the reason why they created the anxiety, but now they've got the anxiety, they're producing all this oxidative stress that actually has to be addressed. And the research has shown that oxidative supplementation may play an important role or therapeutic role in combating oxidative stress individuals that suffer from anxiety. So what is it? So oxidative stress is the excessive production of free radicals and really the failure of the body's primary and secondary antioxidant defense mechanisms to keep up with it. So being low in antioxidants can decrease this protection against these reactive oxidative species and reactive nitrogen species. These are very reactive, very toxic byproducts of metabolism. They damage your nerve cells and your proteins and your lipid membranes and DNA, and they damage into the mitochondria, which is the mitochondria can't function very well as a result of this oxidative stress. And this is where you get all these other secondary types of symptoms and fatigues and all these other things that develop from it. And really, in a way, the information, so that antioxidant compounds may be a new strategy for prevention or reduction of anxiety levels, particularly when there's a deficient level of it in the body. And this was quite an interesting study where they sort of, I probably want to put this in more for the impact of seeing how such a humble antioxidant, vitamin C, we often, as clinicians, we often want to find the next cutting edge antioxidant, this next, great one, whether it be, wherever it is, whether it's catalase or whether it's trying to build up the glutathione or all these. This particular study was good for me to show how a humble vitamin C, 500 milligrams, and what impact that can particularly have over. And in this study, they had 42 students. They were randomly allocated into basically a vitamin C or a placebo. They took the 500 milligrams, took it for 14 days, and they found that that vitamin C significantly decreased the stress levels compared to the placebo group. The vitamin C had a significant anxiolytic effect. This is 500 milligrams. It decreased the heart rate, and they suggest that having at least a diet rich or having plenty of vitamin C can reduce the anxiety levels. And further to the study, that when they looked at the mechanisms of why is this just a small amount of vitamin C doing this, they found that vitamin C may reduce anxiety and relieve stress because it stimulates the GABA binding properties, and also blocks another, we haven't really gone into the NMDA, but another important channel that often is implicated in anxiety, and has impact over the dopaminergic and glutaminergic systems. And they find that it can modulate the catecholamines. This is all these releases of those acute chemicals and norepinephrines and the dopamines and the the adrenalines. It can actually modulate and decrease these levels over, and you get this faster recovery of salivary cortisol. And that's just using 5 milligrams of vitamin C. So it's sort of good to really appreciate how we can not only use antioxidants, but which ones we can choose, or which ones can still have a significant impact over. The other problem with oxidative stress, and really when it comes to mental health, including anxiety, you really can't get away from zinc, and particularly zinc and P5P. You really can't get away from them because they're so crucial in regulating neurotransmitters, and so crucial in regulating, gut health and all the mucous membrane strength of the body there. So in this oxidative stress, that oxidative stress depletes all your zinc stores. And really, when you get the low zinc, it alters and reduces your GABA levels. It impacts the NMDA receptors. It makes it very difficult to convert your pyridoxine hydrochloride, which is often found in a lot of supplements there, into P5P, the active form that's found in the body. You can't convert that over. And we also know when you sort of block out the zinc and the copper have this sort of antagonistic sort of relationship there. So to keep copper under control in the body obviously relates very heavily to your zinc status. And if you sort of knock out your zinc, the copper level doesn't have anything to hold itself out. So copper overload can alter the norepinephrine and dopamine levels and cause a whole series of consequences and symptoms and anxieties and things like that happen out of that imbalance alone. But the good thing is that when you want to treat this, is that you can correct the low zinc low zinc status even within a 2-month time period. You've got a good way to get that back in and have a significant impact over on correcting low stores. But in terms of anxiety, when we look at particularly zinc in relation to anxiety, this was a bit of an interesting study. It was more of a slightly more case control type of written up study. It wasn't necessarily a double-blind placebo-controlled level. But what they did is they wanted to see the impact basically of zinc supplementation before and also after in the patient there. So they wanted to see what this status was like before supplementing over, and seeing what impact that was going to have at the end of the trial period. They had 38 individuals, all diagnosed using the Hamilton Rating Scale for anxiety. They basically gave zinc supplementation. Interesting enough, they didn't actually define down exactly what level of zinc. I kept on looking for exactly what amount of zinc they were doing, but they didn't actually just disclose that into the particular paper, which was a little bit unusual. But they gave the zinc for a minimum of 8 weeks. And they also gave a bit of an antioxidant therapy over. They gave a bit of vitamin C, vitamin E, the B6, and some magnesium. They didn't do it for every patient, but they did it for most. So, like I said, this was more of a case series. It wasn't quite a clinical design where they're using one therapy or one agent and just looking at the effects over. The results in the plasma levels, before they gave over these supplements, was that all the patients that had this anxiety had high plasma levels of copper, and they had this really high copper, low zinc ratio, and all had basically low and lower zinc when they compared to the controls. So the anxiety patients were just high levels of copper, low levels of zinc. And they basically, the conclusions in the results, they basically suggest, yes, there is an association between the zinc plasma levels and individuals experiencing anxiety. And providing a zinc over does play a role in improving symptoms. And the reason why they sort of came in and explained it, they basically, essentially the low zinc is possibly associated with this concurrent oxidative stress. So oxidative stress will deplete low zinc levels. And this implication of this can lower the GABA, impact the glutamate levels, and basically has an impact on the anxiogenic effect. And basically, when you supplement zinc, you can raise your GABA levels and improve anxiety symptoms. This was just another study where they kind of looked at generalized anxiety disorders. They just wanted to look at all the trace elements in generalized, clinically diagnosed generalized anxiety disorders. So in a way, aim to determine the concentration of serum trace and essential elements in these types of patients. And again, the results showed a significantly decrease in serum zinc concentrations when they compared to the placebo group. They also found the copper, manganese, iron were significantly higher. So again, the zinc, copper, manganese, again, is a bit of a triad of minerals that sort of actually work quite closely together, but you knock out the zinc, and the copper and the manganese often do lose some controlling mechanisms. Interesting, in this one of the 50 patients, they didn't find implications of calcium magnesium, but that was just part of that participation group. So the B6, I mean, zinc obviously is major for your neurotransmitters. Of course, B6 is. There actually are 3 forms of B6. We only really have 2 that we can use in supplements. One of the major pharmaceutical companies many years ago, I don't know how they went, but they tried to patent the other form. They tried to patent the other form of natural B6. I'm not sure where they went with it, but I remember seeing that going through the literature probably maybe 5 or maybe even longer, maybe 7 or so years ago, and thinking, oh my God, they're trying to patent this natural vitamin. But anyway, we do have the pyridoxine hydrochloride. That's the most common you generally find, but obviously in P5P is becoming a lot more available. That's the active form that the body uses. Though we do know that zinc, obviously, as mentioned before, converts the pyridoxine into P5P. So zinc becomes a major partner to P5P. P5P regulates about 80 enzyme systems, and including the synthesis of your serotonin, GABA, and dopamine. And they've found in clinical trials that you can actually normalize your neurotransmitter levels, have the same effect as SSRIs, SNRIs, other forms of medication when you just use P5P, B6 alone. So really to appreciate how powerful this particular vitamin is. It's remarkably powerful, even when you compare it to medications. And anyway, if you think about the impact of not having these key vitamins and minerals in your system, or not addressing them, or not investigating them there, you're just not going to be able to restore and regulate these major important neurotransmitters that are implicated in anxiety. Now, we've had this question over time. I thought I might address it here. Often we do use a combination of, not always, but in certain formulations, we do use a combination of pyridoxine hydrochloride and P5P together. And Henry has done this for a long period of time, and also created a bit of a trend in the, out there of why this combination has been done. And the reason why I did this, generally basically during the 60s and 70s, there was this Dr. Cal Pfeiffer, which was a pioneering researcher in mental health, essentially using nutrients to improve major mental health disorders, from schizophrenia to bipolar and autism and all these particular kind of areas. And they developed one of the largest databases of blood biochemistry in the world, and it's still one of the highest in the world today. And what they found after decades and decades of trial and error, they found that some patients, when they gave pyridoxine hydrochloride and they tested and provided all this biochemistry results, a lot of patients were failing to get results out of pyridoxine hydrochloride. And then they discovered the implications of zinc coming in, and zinc's not maybe converting it over properly there. So then they tried P5P and found that some patients responded much better to the pyridoxal 5-phosphate. But then they also found that some patients weren't responding to pyridoxine 5-phosphate, surprisingly, and they're responding to the pyridoxine hydrochloride. So there's something happening in the biochemistry between these 2 forms of B6 that very difficult sometimes to completely explain. I've seen some researchers explain that in leaky gut, and sometimes leaky gut absorbs the P5P up, and that can get into the body a little bit differently. And I've sort of seen various forms of ideas around it there. But essentially, back in the 80s, Dr. Cal Pfeiffer, along with the William Walsh Institute, started combining the 2 forms together, and found they actually got much better therapeutic results when they combined the pyridoxine hydrochloride with the pyridoxal 5-phosphate. And hence, that's why you do see that combination in a lot of our formulations there. One element of warning, and this probably comes down to the dosing areas, and we're probably not too much problematic in our area, but when people start to use 200, 300, 400 milligrams of B6, particularly more the pyridoxine hydrochloride, and the patient has sufficient levels, this is where you can sometimes get reactions. But generally, the high doses are when you start to use the 200 to 300 high milligrams, and I don't think most of us really always prescribe in that fashion, unless we may be focusing directly on pyrroles and Mo factor. In terms of testing, we often get these few questions. The testing, and probably won't go into the reasons why, but basically we do reckon the plasma zinc is probably one of the best tests to use in terms of trying to identify the zinc status. And whereas the B6, the gold standard test, is the transaminase stimulation blood test. And this is where if you want to use some form of functional pathology to test patients, they're the ones we do recommend. Zinc citrate, Henry's long regarded zinc citrate. We do use all forms of zinc, including zinc citrate. This was a study that did basically show that that basically the human, basically mother's milk is actually in the zinc citrate form. So Mother Nature created the absorption component of zinc to be done in. Sorry, I'll say it again. Mother Nature created in breast milk the component of zinc to be bounded with zinc citrate, because when providing zinc over to the infant has a very immature digestive system, needs to absorb up zinc very well, and the zinc citrate's been used. And this was one of the first studies of its kind that identified that it was actually zinc citrate that was found in breast milk, and that's the preferred carrier. Step 3, this is about the structural and functional considerations. This is something where I know omega-3, I know that a lot of patients might be on it, and we might, we still always have to screen the omega-3s. There is issues with the deficiency still happening, not getting food sources readily. Most food sources are really coming from meat. Most, meat has a small amount of omega-3, but all the other issues with it, most people are getting their omega-3 status from the diet is actually through meat. But deficits in omega-3 are reported in anxiety disorders. Preclinical data shows that omega-3 is an effective treatment, both and also preventive in anxiety disorders. And it's not surprising that omega-3 impacts your neurotransmitters and impacts the inflammation component, as we know. It's also antioxidative. It will reduce a lot of those oxidative byproducts as well. So it's actually important to always assess and look at the omega-3 status. Just quick few things on omega-3. There's basically a lot of preventative benefits on anxiety disorders due to the impact on the immune system, on inflammation, on the transduction, neurotransmission, and neuroprotection. So all the nerve cells that manufacture and transmit your neurotransmitters, they all require omega-3. So without having omega-3, you can impact. So you might be able to create the precursors to your neurotransmitter, but if you're not getting neurotransmission, or if there's inflammation that's causing this neuro breakdown, or free radicals are causing the impact on the nerve cell, then you may not get the transmission of these neurotransmitters into the nerve synapses to begin with. Omega-3 helps with that. Studies do suggest that probably the EPA fraction is probably the one that's doing more of the impact. As researchers want to do, they want to break down, is it EPA and DHA, even though all fish has a combination of various levels of both. But as researchers want to do, they want to go, is it the EPA or DHA? Just for their sake, they found that the EPA fraction is probably the one that's doing more the impact on anxiety. DHA is doing all the other wonderful things, but in terms of anxiety, it's the EPA version that's doing. They do have a lot of supportive literature where the high EPA is doing some positive things, but this is where they use a combination of EPA and DHA, so quite a fairly slightly high percent of EPA compared to DHA. They found the omega supplementation had additional effects on decreasing both depressive and anxiety symptoms. So just as wrapping up now, step 4, it is the last step. It is something that's, again, you can't really establish long-term support without impacting lifestyle, without impacting diet. You can employ counseling techniques, which are vitally important. Behavioral cognitive therapy, very, very important in this. So we don't want to just say that it's just biochemistry alone and that's going to solve the issue. It won't. It's going to have the foundational support. It's going to have it's going to impact very, very effectively over. But ultimately, you need to go through what you guys do best and identify dietary problems and identify these issues that are also coming through that also have to be addressed.